So we'll be starting with the most basics, and what I'm thinking of today is I'm thinking to flood you guys with maximum number of ECGs. Okay, so I'll be showing you maximum number of ECGs. We'll not be discussing about theories. We'll not be discussing about the interval triangles. Those are all the fancy things about ECGs. But what we need to know in real life practice is something else. So we'll be discussing the basics that we need in our real life practice. Okay, interval triangle, how to calculate an axis, those are all the fancy things of ECGs, and we are not going to discuss this now, because as you all guys know, this is a 1 hour session, and within 1 hour we have certainly got limitations. Okay, why we plan such a session it is because as an house surgeon, when I was a house surgeon, I am actually a graduate of Calicut Medical College. So when I was a house surgeon, I was reluctant to see ECGs. Like whenever I get an ECG, I directly pass it on to PG, and PG will even not take ECG from my hand. They'll just look from it a far point, and they'll comment it. They'll say like it's LBBB. They'll say it's like SVT. And I was just wondered how they can read ECG so quickly. So what I need to tell you guys, or after this session, you guys should also be able to read ECGs in that speed. Most importantly, the most difficult task in an ECG is not picking up a STEMI, it is not picking up an AF, it is not picking up a VT. The most difficult task in an ECG is to report an ECG as normal. Okay, the most difficult task in an ECG is to report it as normal, because we know that we have certain rhythms in ECGs. Okay, we have certain rhythms in ECGs. So we know a classical ECG looks like this. Okay, we have studied it from 12th class. This is the P wave, this is the Q wave, this is the R wave, this is the S wave, and this will be the T wave. So this is how a classical ECG looks like. But in real life, you won't see a classic waves like this. Okay, you will never see waves like this. It will be little bit what we expect. It will be not up to our expectations. There will be some variations from the classical ECG findings. So reporting a ECG as normal, that means I can send this patient back to home. I have no purpose to send or refer him to a higher center. Making such important decisions is the most important thing. So let's move on. I'm actually not an expert, but what we are going to discuss here is the ultra basics of ECG. So can you guys just give me a quick feedback? Is the class fine? Are you guys able to catch up? Is there any necessary changes that I should make? Please comment, and we'll be making those necessary changes. So moving on to the basics. So speaking about the squares of ECG. So we know that ECG has large square and small square, and 5 small square makes 1 large square. Okay, 5 small squares makes 1 large square. Okay. So, and here at this point, you need to know the duration of 1 small square. 1 small square is equal to, this will be important or necessary to read ECGs. 1 small square is equal to 40 milliseconds. Okay, so 5 small square is equal to 1 large square, and the duration of 1 small square is 40 milliseconds. I hope it's clear up to this point. Okay, now speaking about the leads. So we have in ECGs, we have got chest leads and limb leads. And chest leads, I'll show the figure. These are the chest leads. So chest leads we have from V1 to V6. They are placed from the right side of the chest towards the left side of the chest. So these are the chest leads, V1, V2, V3, V4, V5, and V6. Of these, V1 lies to the right of the sternum, and the rest of the leads lies to the left of sternum. Okay. Okay, you are able to catch up. Okay, fine. So these are the chest leads. Now, other than chest leads, what we have in ECG is the limb leads. So I'll just zoom it. So these are the basics, guys. I just want to know what all we have in ECGs. That's how we start. Okay, without telling the leads, I can't proceed to ischemic changes or the changes in MI. So we have spoken about the chest leads. I have also shown you where all we will place the chest leads. Now speaking about the limb leads, we have lead 1, lead 2, and lead 3. Okay, so we have unipolar limb leads and bipolar limb leads. So we have lead 1, lead 2, lead 3, and we place a lead perpendicular to lead 1, which is called lead AVF. Okay, we place a lead perpendicular to lead 2, which is called lead AVL, and we place a lead perpendicular to lead 3, which is called lead AVR. So these 6 leads makes the unipolar leads. These 6 leads make the, sorry, not unipolar leads. These 6 leads make the limb leads, and we have chest leads. So how these are connected, that's all. Again, so it's all about dealing with the fancy part of ECG. We don't need that for reading an ECG. Actually, we need that, but at our level, we just need to know the most important things of ECG. So we know that there are chest leads and there are limb leads. Okay, so that's about the leads of ECG. Now, speaking of the waves of ECG, about waves of ECG, as you guys all know, there are three waves. Usually there are three waves. There can be waves which are more than three, but usually there are three waves. One is P wave, which represents atrial depolarization. There is QRS wave, which represents ventricular depolarization, and there is T wave, which represents ventricular repolarization. These are the basics which all of us know. And now the fourth part is intervals. So speaking about the intervals, we can speak about many intervals and many segments. But what we need most is clinically only two intervals. One is the PR interval. Okay, one is called the PR interval. So PR interval in ECG is from beginning of the P wave, to beginning of QRS. Beginning of P wave to beginning of QRS. So this is called the PR interval. This is important, guys. I am only speaking about the important points here. So what I am speaking here, you should not skip. Okay, because I have already filtered this. So PR interval is from beginning of P wave to beginning of QRS. And the usual duration of PR interval is 3 to 5 small squares. Usual duration of PR interval is 3 to 5 small squares. And I have already mentioned you that 1 small square is equal to 40 milliseconds, which means 3 to 5 small squares will be 120 to 200 milliseconds. I hope it's clear up to this point. Okay. So that's about PR interval. I'll be discussing this again and again, and you guys will be able to catch up it better. But for the time being, just know PR interval is from measured from the beginning of P wave to beginning of QRS, and it makes about 3 to 5 small squares. And as I already mentioned, 1 small square is equal to 40 milliseconds, which means 3 to 5 small squares will be 120 to 200 milliseconds. I hope it's clear. And about one more duration I need to mention here, because it's again important. That is the duration of a normal QRS. Duration of a normal QRS is around 3 small squares. A normal QRS is around 3 small squares, which means its duration will be 120 milliseconds. So these are the basics. I have written each and every basic you need to know to read an ECG. Okay. In this slide, we have all the basics you need to know. So once again, I'm just revising. We have squares. Squares will be small squares and large squares. 5 small square is equal to 1 large square. That's our first point. 5 small squares will be equal to 1 large square. And secondly, I'll be speaking about the duration of the small square. The duration of one small square is around 40 milliseconds. That's the second important point. Okay, and we have spoken about the leads. About the leads, we have spoken. There are chest leads, there are limb leads. Okay, chest leads is from V1 to V6. Limb leads, we have lead 1, lead 2, lead 3, and we have lead AVR, lead AVL, and lead AVF. Okay, and thirdly, we have spoken about waves. That's ultra basic. Everyone of you will be knowing that we have P wave, QRS wave, and T wave. Okay, and finally about intervals, which is important. We have spoken about the two interval or two durations in ECG. One is the PR interval, which is marks from the beginning of the P wave to beginning of QRS, and its normal length is around 3 to 5 small squares, and which the duration of which will be 120 to 200 milliseconds. And secondly, we have already also mentioned the duration of a normal QRS, which is around 3 small squares, and its duration will be 120 milliseconds. I hope up to this point it's clear to everyone. Okay. So can you guys just please comment? I just need to know, because as this is our first session, I just need to know whether you guys are able to catch up. Okay. Is it clear? Yes, it is clear. So with these basics, we are moving on. So once again, I'm saying these are not the only basics we have. We can say how each way, how the isoelectric line is formed in ECG, why P wave is a positive deflection, why do Q occur before R, all those have got reasons. But for the time being, in a 1 hour session, this is what we need. And again, when you deal a patient in casualty, this is the only thing you need. Okay, for our level. Now, let's speak about the placement of leads, and this will be important when you deal with conditions like ischemic changes. Like in MI, this will be important. So This is the 3D representation of Einthoven's triangle. So you know Einthoven's triangle, it's basically arrangement of different vectors. And when we arrange, I will be not detailing about this because it will take much time. But just know when we arrange different leads in Einthoven triangle, what happens is lead 1, lead AVL, and lead V5. This is lead V5 and this is lead V6. These all leads come together. And these 4 leads represents the lateral wall of a heart. These 4 leads represent lateral wall. Is it clear? So lead 1, lead AVL. So guys, okay. Actually, somebody is asking, is QRS an interval? QRS is not an interval, QRS is a wave, but I have just mentioned the duration of QRS just because we will be needing it. Because we have wide QRS, we have narrow QRS, so you need to know what a wide QRS is. For that purpose, I have mentioned the duration of QRS there. QRS is actually not an interval, QRS is just a wave. Okay, I hope it's clear. So let's continue. So with these basis, I'll be showing you many ECGs now, and you can interpret, you can diagnose each ECG by yourself. So what happens is we have lead 1, lead ABL, lead V5, and lead V6. They all come together, and these 4 leads comprises the lateral wall of heart. Okay. Now lead 2, lead 3, and lead AVF. These 3 leads come together, and these 3 leads comprises the inferior wall of heart. Okay, so these are the basics, guys, because you need to know which all leads corresponds to which all walls. Only then you can diagnose an ischemia, or only then you can diagnose an MI. So whenever you see an ECG, there is some way how your eye should go in ECG. It's not like we read lead 1, then lead 2, then lead 3. It's not like that. I'll show you how to read. But this you need to understand that one AVL, lead 1, lead AVL, lead V5, and lead V6, they represent the lateral wall of heart. Lead 2, lead 3, and lead AVF represents the inferior wall of heart. And lead V1 to V4, we have lead V1 to V4 left here, and this represents the anterior wall of heart. This represents the anterior wall of heart. And of those, V1 and V2 is septal, and V3 and V4 is the proper anterior. But even if you don't know that, it's fine. But you just need to know that V1 to V4 represents anterior wall of heart. So these are the 3 most important wall of heart. And corresponding to these leads, there will be changes in ischemia. So these you should learn at this point itself. Only then we can move further. Because without knowing which all lead corresponds to which all wall, we cannot diagnose a MI. So is it clear? So lead 1, lead AVL, lead V5, and V6. If you are taking notes, it will be good. And just note that lead 1, lead AVL, lead V5, and lead V6 represents the lateral wall. Lead 2, 3, and AVF represents the inferior wall. And lead V1 to V4 represents the anterior wall. Of those, lead V1 and V2 is septal, and V3 and V4 represents the proper anterior wall. I hope it's clear to everyone which all leads represents or corresponds to which all wall of the heart. So let's move on. So this again I am showing. Just I want to revise. Lead V1 and V2. Lead V1 and V2 that actually represents the septal wall or the interventricular septum. And lead V3 and V4 is proper anterior wall. But I have already said, as I already mentioned, we can call all these lead as anterior wall. So V1 to V4 is actually anterior wall. Is it clear? Lead 1, lead AVL, lead V5, and lead V6 represents the lateral wall. This we have already mentioned. And lead 2, lead 3, and lead AVF. These 3 leads represents the inferior wall. I hope it's pretty clear to everyone. That's why I have revised it. Okay. Now let's move on. So this is basically how it went. I will first show you a normal ECG. I'll first show you guys a normal ECG. So this is a normal ECG. So this is how a normal ECG looks like. So I hope it's clear. This is lead 1. Hey guys, this is lead 1. This will be the usual position of lead 1 in a normal ECG. This is lead 2. This is lead 3. This is AVR. This is AVL. And this is AVF. And all together, these 6 leads make your limb leads. So this is lead 1. This is lead 2. This is lead 3. This is AVR. This is AVL. And this is AVF. And here we have leads V1 to V6. This is V1, V2, V3, V4, V5, V6. This is how a normal 12 lead ECG looks like. What we take usually is a 12 lead ECG, and this is how a normal 12 lead ECG looks like. And you guys see a separate wave here. You might be having doubt that what lead is this. This is actually not a lead. This is called the rhythm strip. This is called the rhythm strip, and this is usually present in our routine ECGs, but not always. Usually what you find is these 12 leads. In a normal ECG, this is a normal 12 lead ECG. We call it a normal 12 lead ECG. Lead 1, lead 2, lead 3, lead AVR, lead AVL, lead AVF, and lead V1 to V6. Okay. Now, whenever we look in an ECG, important thing is that if you are considering an ischemic change, that means if you are looking for an MI, if you are looking for an infarction, how you will interpret is after looking 1, you will look on to AVL. After looking to 1, you won't look to lead 2 or won't look to lead 3. After looking to 1, what usually you should look is towards lead AVL. And after AVL, you won't go to AVF. After AVL, you will go to V5, V6. And I think by this time, you guys might be pretty sure, or you guys might be knowing why I look ECG in that way. Because lead 1, lead AVL, and lead V5 and V6 makes the lateral wall. That's why I am looking ECG in that pattern. So after looking at lead 1, I'll look on to lead AVL. And after looking to lead AVL, I'll look on to lead V5 and lead V6. Is that clear? Okay, that's how we interpret an ECG. Because even though ECG is arranged like lead 1, lead 2, lead 3, the walls of the heart chamber corresponds like this. That is, lateral wall corresponds to lead 1, lead AVL, and then lead V5 and V6. Okay, now if I find that these leads are normal, so you can find in this ECG, I hope it's clear. Can you guys point out the waves and the leads from this ECG? Or I should magnify it more? Should I magnify it more? I hope it's fine. Okay. So let's continue. So after looking at lead 1, I look on to lead ABL, then on to lead V5, and then on to lead V6. Okay, if I see that these leads are normal, now I am going to look on to lead 2. Okay, so we know that lead 2 makes the inferior wall of the heart. And after lead 2, the next lead which comes is lead 3. Lead 3 also makes the inferior wall of heart, and the next lead which comes is AVF. So after looking 1 AVL, V5, V6, the next thing I am going to look is lead 2, 3 AVF, because these 3 lead makes the inferior wall of heart. Is that clear? Okay, now I have done with inferior wall, I have done with lateral wall. What is remaining? We have the anterior wall. That is, now I look on to lead 1, lead 2, lead V1, lead V2, lead V3, and lead V4. And these 4 leads makes the anterior wall. This is the way you look to an ECG. Not like reading lead 2 after lead 1, lead 3 after lead 2. It's not the way. After looking lead 1, and one thing important that we need to speak here is, this is the pattern we look on to ECG if we are suspecting an ischemia or an MI. Okay, for an arrhythmia, we don't need this. Only for ischemia, this is the pattern. But what we encounter clinically most of the time is ischemia. That's why I'm dealing like this, or that's why I'm discussing the session like this, because 80% of time or 90% of time when you are in casualty, you are going to look for ischemic changes. Only in 10% of time you are going to look for arrhythmias, you are going to look for bundle branch block and all. Okay, so this is the way we look onto ECG. I hope it's pretty clear. So we know these are the in the basic session I have discussed that we have large square. This is the one large square, and each large square contains 5 small squares, and each small square is 40 milliseconds. Okay, then all we have already discussed. And PR interval. One important thing about PR interval is, when we say PR interval, what was the definition of PR interval? PR interval is that interval which starts from the beginning of P wave. Guys, that is important. It's not from the end of P wave. Like if I draw an ECG like this, my PR interval is from the beginning of the P wave. It's from this point, guys. It's not from this point. Okay, it's not from this point. It's from this point. That is, it marks the beginning of P wave to beginning of the QRS. Okay, so this makes the PR interval. And a normal PR interval, as I already mentioned, it is 3 to 5 small squares, or 3 to 5 small square makes 120 to 200 milliseconds. So one thing important you need to remember from this is VR interval starts from the beginning of P wave. Okay, so we have discussed how to look for an ischemic change in ECG. So this is the way your eyes should follow in ECG. So once again, I'm showing it to you. So this will, so this is the pattern how an ECG look like. So this is the pattern somebody saying to magnify. I have already magnified. So this is the pattern how an ECG will be looking like. Okay. So we have the lead one. So after lead one, this is the lateral lead. The second lateral lead is AVL. The third lateral lead is V5, and the fourth lateral lead is V6. So this is the pattern how we look at ECG. After one, we look on to AVL, then to V5 and V6. Then we'll come to the next wall of heart. We have done with the lateral wall. We'll now come to lead 2, lead 3, and lead AVF. Those makes the inferior wall of heart. And the rest is V1 and V2 is septal, as I have mentioned. V3, V4 is anterior. And together, we can call V1 to V4 as anterior. There's no harm in calling like that. Okay, so you will definitely be having doubt what this AVR leads to. But if I start discussing about that, our session will not be contained in 1 hour. So I hope for the time being we can leave AVR there. Okay, so this is how we interpret an ECG. So after discussing this, let's start about the basics of an ECG. So up to this time, is the session clear, guys? Is there any changes that I need to make? Please mention in the chat box. Is there any changes that I need to make? I'll make the changes and I'll continue. Please let me know, is there any changes that I need to make, or you guys are satisfied, or you guys are able to follow up? It's all good. Okay, so let's continue. So let's discuss about the, actually my phone battery will die now, but I hope it will be fine. So let's start. So speaking about the rate, we'll be discussing certain points, not all points, but certain points we'll be discussing. So how to calculate? We have many equations, but in emergencies, again, you don't need many equations. You just need one useful equation. That is to calculate rate of an ECG. To calculate the rate of an ECG, the equation that we can use, the most useful equation we can use is 300 divided by number of large squares between two R waves. Okay, so to calculate the rate of an ECG, what we can use is the rate is equal to 300 divided by number of large squares between two R waves. Is it clear? So we have another equations also. We have 1500 divided by number of small squares, but as I am mentioning again, in emergencies we need one good equation. Rather than many equations, we need one good equation that we can use. So 300 divided by number of large squares gives you the rate of the ECG. So coming back to this ECG. So let's count. We have about 1, 2, 3. This is one R wave. This is the second R wave. Okay, this is one R wave, and this is the second R wave. I shall magnify it a little more for you. Okay, see. So in a 12 lead ECG, one minute, guys. There's a small technical issue. So I'll just show you in another ECG. See. So in this ECG, this is one R wave. We have one R wave here. We have one R wave here. We have the second R wave here. So between two R waves, I'll count the number of large squares. So we have around 1, 2, 3, 4, and 5. We have around 5 and more than 5. Actually, it makes more than 5 because we have some small square here, some small square here. So it makes more than 5. So my heart rate here will be 300 divided by more than 5. Let's take it as 6. So it's more than 5. So I'll take it as 6. So 300 divided by 6, my heart rate here will be 50. Okay, so that's how you calculate. So that's about rate. So we'll count the number of large squares between R waves and we'll divide that by 300. So 300 divided by number of large squares between two R waves gives you the rate of the ECG. I hope it's clear. Okay. Now, can you please write with yellow or other bright colors on blue background? Of course, I'll look at. So now let's move on. Now I'll be discussing what is a sinus rhythm. Now I'll be discussing what is a sinus rhythm, because these terms you will be hearing again and again while discussing ECGs. That is what is a sinus rhythm. Sinus rhythm simply means one thing. That is, let me let me charge my phone, else it will be dying. Okay, so what is sinus rhythm? So sinus rhythm has just only one meaning. That is, every P wave is followed by a QRS. Every P wave is followed by QRS. If every P wave is followed by QRS, we call it a sinus rhythm. So sometimes I'm using dark color, sorry for that, but I'm dictating along with it. So I hope it's clear. So we call it a sinus rhythm when every P wave is followed by a QRS. So naturally, by this definition, by hearing this definition, you can understand that there will be instances where every P wave will not be followed by a QRSS, and we call it a hard block. Okay, I'll come on to that point, but just for the time being, understand that sinus rhythm is when every P wave is followed by a QRS. Okay, now coming on to these ECGs. So I'll just show you. Okay, sorry for the delay, guys. Actually, there was a technical issue. So I hope we can continue. So I'm discussing about, so we have discussed about rate, we have discussed about how to calculate rate, we have told the equation to calculate rate. Now let's move on to rhythm. So speaking about rhythm, we need to know. So before moving on to rhythm, I just need to know what a normal rate is. So our normal rate is between, normal heart rate is between 6 to 100. 60 to 100. Okay, normal heart rate is between 60 to 100. So if you have heart rate below 60, we know that we call it as a bradycardia. And if you have a heart rate more than 100, we call it as tachycardia. That's pretty clear. I know everyone will be aware of that. So normal heart rate is 60 to 100. If your heart rate is less than 60, we call it a bradycardia. If your heart rate is more than 100, we call it a tachycardia. So that's about the rate of an ECG, and I'll show you how to calculate the rate of ECG. For this ECG, we have already calculated the rate. The number of boxes between two R waves here is around 6. So the rate here will be 300 by 6, which gives me 50. And since it is 50, we know that 50 is less than 60. And since it is less than 60, we can call this ECG to be an ECG with bradycardia. We can call this ECG to be an ECG with bradycardia because our heart rate here is less than 60. Okay, I hope it's clear. Now, moving on to this ECG. Here, number of boxes between two R waves is around 2, because here we have one full box and 4 small squares here and about 1 small square here. So we can take that it as number of large squares between two R wave here is 2. So my rate here will be 300 by 2, which gives me 150. And we know that 150 means it is more than 100. And if it is more than 100, this ECG, we can say that the heart rate of this ECG is in tachycardia. So this is an ECG with tachycardia. This is an ECG with bradycardia. I hope it's pretty clear. So by looking itself, so this is how we calculate. But over time, when you see more and more ECGs, just by single glance, you can tell whether ECG is in tachycardia or bradycardia, because you will be conditioned to it. Okay, so whenever you see more and more number of ECGs, we can just by a glance we can say whether an ECG is tachycardic ECG or a bradycardic ECG. So I hope it's clear to everyone. Here the rate is around 150. Here the rate is around 50, and this is a ECG with tachycardia. This is an ECG with bradycardia. Now, whenever you see tachy and brady, this is something important you need to remember. One is, whenever you see tachycardia at our level, at a level of an house surgeon, what we need to remember is tachycardia can be usually seen in 3 conditions. If you're taking notes, please note this down. One is sinus tachycardia. Second one is SVT, that is supraventricular tachycardia. I'll show you how an SVT looks like. And third one is VT, that is ventricular tachycardia. So these are 3 conditions where you can see ECGs with tachycardia. I never want to mean that these are the only 3 conditions where you see tachycardia, but most importantly, these are the 3 conditions where you see tachycardia. One is sinus tachycardia, one is SVT, and one is VT. And speaking of bradycardia, you can see it in many conditions, but usually you need to remember 3 conditions here. One is sinus brady, and the second one is heart block. One is sinus brady, and second one is heart block. Is it clear? Okay. Now, I already told you what is sinus rhythm. What was sinus rhythm? Sinus rhythm means every P wave is followed by a QRS. Sinus rhythm means every P wave is followed by a QRS. So let's move on to these ECGs again. Here you can see that every P wave is followed by a QRS. Every P wave is followed by a QRS. Every P wave is followed by a QRS. That means this ECG has sinus rhythm. Also, this ECG has tachycardia. And when you combine this both, we can say that this ECG is sinus tachycardia. I hope that point is pretty clear to everyone, because this is a sinus rhythm. Why is this sinus rhythm? Because every P wave is followed by a QRS. And why this ECG has tachycardia? Because its heart rate is more than 100. So this ECG has sinus rhythm. This ECG has sinus tachycardia. Combining those two, we can say that this ECG is a sinus tachycardia. Now, again, you can look here. This P wave is followed by a QRS. This P wave is also followed by a QRS. This P wave is also followed by a QRS. Again, the second ECG is also in sinus rhythm. And since we have bradycardia here, we call this as sinus bradycardia. I hope it's clear up to this point for everyone. I hope it's clear. Is it fine, guys? Is everybody able to follow me? So this is how you say whether an ECG is in sinus tachycardia or sinus bradycardia. So whenever you see tachycardia in ECG, the three important conditions you need to know is, one is sinus tachy, and I have already showed you the ECG of sinus tachy. This is the ECG of sinus tachy. Second one is SVT, third one is VT. I'll show you ECGs of SVT and VT. And whenever you see bradycardia, that means whenever your heart rate is less than 60, the two important things, other than this, we can have junction rhythm with bradycardia. There are many conditions, interventricular rhythm. There are many conditions which will be bradycardia. But most importantly, these are the two conditions which usually comes as bradycardia. One is sinus bradycardia, and second is heart block. I have already showed you the ECG of sinus bradycardia. I'll show you the ECG of heart block. I hope it's pretty clear. Now, let's speak about rhythm. So, we can have two types of rhythm in ECG. One can be regular rhythm. One can be the regular rhythm, and second can be an irregular rhythm. One can be a regular rhythm, and second can be an irregular rhythm. What we mean by regular rhythm is the R waves occurs at regular intervals. Okay, we call in ECG regular if the R wave occurs at regular intervals. For example, when you see this ECG, you can see that after every 6 large squares, you get an R wave. The distance between this R wave and this R wave is 6 large squares. Again, the distance between this R wave and this R wave is also 6 squares. The distance between these three R waves, these two R waves are also 6 squares, which means the distance between every successive R wave is 6 large squares. So this ECG is regular because the QRS wave or the ventricle is beating at a regular interval. That's why we call these ECGs regular. Okay, I'll show you irregular ECGs. Then you will come to understand better. But for the time being, understand that if the number of large squares between every successive R wave is equal, we call that ECG to be regular. And majority of ECGs which we come across in our daily life will be regular. Okay, I hope it's fine. Now, what is an irregular ECG? We have defined a regular ECG. From that, you can understand or you can assume what an irregular ECG. It's simple. That means the number of large squares between two R wave will not be equal. I will show you ECGs. Okay, that means between first and second R wave there may be two squares. Between third and second and third there may be three. Between third and fourth there may be again two. So the number of R waves between two successive R waves is always not equal. If it is so, then we call that ECG as irregular ECG. And at this point itself, again, if you guys are taking down notes, note down that usually we encounter irregular rhythms first in AF. AF means, this atrial fibrillation. Usually in AF, we encounter irregular rhythm. Okay, now the second one is VF, that is ventricular fibrillation. So these are the two classical ECGs where you get irregular rhythm. So whenever you find an irregular ECG, the most important thing that should come to your mind is first one is AF, that is atrial fibrillation, and second one is VF, that is ventricular fibrillation. I hope it's fine. And some ECGs may mimic as irregular. Okay, those are not actually irregular, but some ECGs may mimic as irregular. And of those, one important thing is ECGs of heart blocks or AV block. These are not truly irregular, but whenever you look, you can see that the number of large squares between two successive R waves is always not equal. So you may think that it is irregular. So Heart block can mimic an irregular rhythm. And fourth one is ectopics, especially ventricular ectopics. It can also mimic irregular rhythm. So why I am listing many points? For example, when I told you sinus brady, I listed you 2 points. When I told you sinus tachy, I listed you 3 points. This is because whenever you see such findings in ECG, these are the important things that should come to your mind. Okay, so whenever you see sinus, whenever you see tachycardia in ECG, what all things should come in your mind? You should think about sinus tachy, you should think about SVT, and you should think about VT. Whenever you see irregular rhythm in ECG, the most important thing to remember is AF and VF, atrial ventricular fibrillation. And after that, you will also need to understand that heart blocks can mimic an irregular rhythm, ventricular ectopic can mimic an irregular rhythm. I hope it's clear. Okay, so let's continue. So before continuing, so I'm almost more than 35 minutes into the class. Is it fine? Is everybody able to follow? Is there any change I need to make? Because this is my first session teaching you guys. So is there anything I need to change? Should I increase or decrease my speed? Is everything fine? If everything is fine, we can continue. It's fine. Okay, everybody is replying. It's fine. So let's continue. So speaking about this ECG, let's see some ECG. So as I promised you at the beginning of the session, I'll be showing you or I'll be bombarding you with many ECGs. So you just need to diagnose what all these are. So first look at this ECG. So whenever I see an ECG, I look at the rate. So just by looking, we can understand that here around there is 2 log squares between 2 waves. So the rate will be around 150 and all. Okay. Now the rate is around 150. That's fine. But the most important thing what I can find here is the number of log squares between 2 waves here is 2. Clear? Here again it is 2. But here it is around 4. So here the number of log squares between 2 is 2. Here again it is 2, but here it is 4. And whenever we have varying number of log squares between 2 waves, we know that it is an irregular rhythm. And whenever we see irregular rhythm, we have two important things in our mind. One is atrial fibrillation and one is ventricular fibrillation. So this is an ECG of atrial fibrillation. This is atrial fibrillation. So two important things that we can find in an ECG of AF is one and foremost most important thing is the ECG of an AF will be irregular. ECG of AF will be irregular. And second thing, you also know that VF is also irregular rhythm. Then why this ECG is not of VF? That is because of simply one reason. Whenever you have impulse from the ventricle, mark these words in your mind now itself. Whenever you have an impulse from ventricle, it will be wide QRS. Because we know that QRS represents depolarization of the ventricle. Okay, I hope it's fine. The QRS represents the depolarization of ventricle. So whenever you get an impulse or whenever you get an arrhythmia from ventricle, you will get a wide QRS. Because since the impulse is coming from ventricle, the ventricle takes much more longer time to contract, and the impulses from ventricle will be usually wide QRS, and impulses which above the ventricle will be of narrow QRS. So if you are noting down, please note this point that if any impulse comes from above the ventricle, we will get a narrow QRS, and if an impulse comes within the ventricle, we are going to get a wide QRS. Okay, so I'll come to that point again and again during the session, but it's a basic and you need to mark these points in your mind. Okay, so an impulse coming from ventricle will be a wide QRS, and impulse coming from above the ventricle means it's simply atria. Above the ventricle, we will be having narrow QRS. So we have seen that it is the rhythm here is irregular. Okay, now the two important differentials in our mind is one is atrial fibrillation, one is ventricular fibrillation. So why this is not ventricular fibrillation? It is simply because the QRS here is narrow. Okay, we have said that the normal duration of a QRS is around 3 small squares. The normal duration of a QRS is around 3 small squares. And you can see that the QRS is here, it's hardly 1 or 2 small square. I'll say it's just 1 small square. And if it's 1 small square, it is not a broad QRS. We call it a broad QRS when it is more than 3. So we call it a broad QRS when it is more than the duration of QRS is more than 3 small squares, then we will call it as a broad QRS. We call an ECG as broad QRS or wide QRS if the duration of QRS is more than 3 small square. That means it simply means more than 120 milliseconds. I hope everybody is clear. about this point. And why is it so? Okay, a rhythm coming from ventricle will take more longer time. So that's why in QRS they will become wide. So, and a wide QRS, we call it a wide QRS when the duration of QRS is more than 3 small square. So simply the first point in this ECG is that this ECG is irregular. So the two important differentials in our mind is one is AF, one is VF. So this is AF. Why this is not VF? Because here the QRS is narrow. Now these are the two important points in AF. And third important point in AF, usually we will have a wavy baseline in AF. Okay, this is also one of the important finding in AF. That means you can see that here it is always wavy. You can never see an isoelectric line. In a normal ECG, we'll get an isoelectric line. So this is after P wave, we have QRs here. This is called an isoelectric line because the voltage there is not varying. That is called an isoelectric line. But in the ECG with AF, we can't see an isoelectric line, and we have reason for that also. But I think if I go explaining reason for everything, we can't contain the session within 1 or 1.5 hours. So let's leave that apart. We can discuss that later. But just remember the most three important findings in ECG of AF will be: one is the rhythm of AF will be irregular. Second one is the QRS. The QRS will be narrow QRS. In a BF, that will be wide QRS. And the third important, most important point in ECG, that the AF will be having a wavy baseline. It will be never having an isoelectric line. You can see it is wavy here, it is wavy here, it is wavy all around. So that's a classical atrial fibrillation. I hope it's clear to everybody. Okay, now let's continue. Now the second ECG here. Second ECG, you can find that it is regular. The range here it comes around 100 because we have around 3 large squares between two QRS complex. So the rate here is around 100. It's almost in tachycardia, but it is regular. And this is the classical representation. You can see that after a T wave, there is a P wave. This is a P wave. So this is something like a sawtooth. This is how a edge of a sawtooth looks like. Right? This is how an edge of a sawtooth looks like. So we have sawtooth waves here. We have a T wave. We have sawtooth P waves. We again have sawtooth P waves. So this is how sawtooth P waves looks like. This is called sawtooth P waves. This is called sawtooth P waves. And we see sawtooth P waves in atrial flutter. This is called atrial flutter. Okay. So of these two, if you ask which is important, 90% of time what you are going to see is atrial fibrillation. You will see flutter, but most importantly, what you're going to see, and most important thing you need to diagnose is atrial fibrillation. Okay, atrial flutter is also common. I have seen many atrial flutters, but most important thing is here is atrial fibrillation, and I hope the 3 points of atrial fibrillation is pretty clear to everyone. In atrial flutter, we will be having sawtooth waves. This is called sawtooth waves that represent the edge of a sawtooth. Okay. Now, there will be a 2 minutes delay, guys, because in this presentation, I can only include 15 slides. We have completed 15 slides. Now, for the next 15 slides, I have to just insert that 15 slides into the system. So, I'll be taking 2 minutes. And within that, now it's 9:30. I think by 10 o'clock, will be able to wind up. So, just a 2 minutes delay, guys. So, let's continue. So, I have shown you atrial fibrillation, atrial flutter. I am seeing some doubts here, but I'll take it at the end of the session because we have to wind it up within at least within 1.5 hours. So I'll take your doubts at the end of the session. Okay, so if you have any, but if you have if you are not able to understand any point, I'll deal with that at the time of discussion itself. But other than that, if you guys have any doubts, we'll take it at the end of the session. Okay, so we have discussed about atrial fibrillation. This is AF, this is atrial flutter. Okay, now let's come on to another ECG. So this ECG, we can leave it now because it's not a classical example. Actually, it's an XVT, but I'll show you better SVT. Let's see this. So again, I'm seeing an ECG here. So I have an ECG here. So first of all, what I'll do here is I'll calculate the rate. So when I calculate the rate here, it's approximately, you can see that there's only 1.5 small squares. It's around 1.5 small square, or I'll take it as 2. Okay, let's take it as 2. 1.5, we can take it as around 2. So the rate here is 300 divided by 2. Our rate here is around 150. Our rate here is around 150. And whenever I see 150, I know this ECG is in tachycardia. And whenever I see tachycardia in ECG, the 3 most important things that come to my mind is one is sinus tachycardia, one is SVT, and one is VT. Okay, now let's see whether it is a sinus tachycardia. I will say this is not sinus tachycardia because here not every P, even you can hardly see P waves here. Okay, here we have one QRS complex, then what we are seeing is T wave. Again here QRS complex, then we are seeing T waves. So hardly you're seeing P waves here. So every P wave is not followed by a QRS, or you can't see P waves in many leads here. So this is not a sinus rhythm. To call it a sinus rhythm, every P wave should be followed by a QRS. So this is not a sinus rhythm because every P wave is not followed by a QRS. So this is SVT. So I have told you that for tachycardia, we have sinus tachy, we have SVT, and we have VT. Okay, we have told this is not sinus tachycardia because every P wave is not followed by a QRS. I have told you that this is SVT. Why can't it be VT? I have already told you the reason. VT means ventricular tachycardia, and any impulse coming from ventricle will be having wide QRS. Okay, so here you are seeing narrow complex tachycardia. Here you are seeing narrow complex tachycardia. Narrow complex tachycardia. That means the duration of QRS is less than 3 small squares. So whenever you see a narrow complex tachycardia other than sinus tachycardia, that means every P wave will not be followed by QRS. It is called SVT. So this is called a supraventricular tachycardia. This is called a supraventricular tachycardia. Why is the QRS complex narrow here? Why is the QRS complex narrow here? It's just because the impulse is arising above the ventricle. And impulses arising from the ventricle will be wide, and impulses arising above the ventricles will be narrow. That's the concept I need to convey. That's why I told you, just note this point because this is important reading while reading every ECG. Okay, so this is called a supraventricular tachycardia. Okay, I told you why do we diagnose this as supraventricular tachycardia? Because this ECG has got tachycardia, but it is not sinus rhythm. That's the first point. So it's not sinus tachycardia. And second point is this is a narrow complex tachycardia. This is not a wide complex tachycardia. Had it been wide complex tachycardia, we can call it SVT. But this is SVT because it is a narrow complex tachycardia. Now let's see this ECG. Now let's see this ECG. Again, here these are the QRS complexes. Like, first of all, let me tell you, this is VT. This is ventricular tachycardia. And why I call it VT, I'll explain. But just know, this is the classical example of a ventricular tachycardia. In ventricular tachycardia, what you see is umbrella-shaped waves. What you see in a ventricular tachycardia is umbrella-shaped waves. Okay, these are just like umbrellas. You see, these are like just like umbrellas. So actually, what these umbrellas are? Each of these are QRS complexes. Each of these are QRS complexes. Then where is my P wave? Where is my T wave? Actually, this P wave and T wave is embedded within. We will be having P wave, we will be having T wave here, but the QRS is so wide that it covers the P wave and the T wave. The QRS is so wide that it covers the P wave and the T wave. Okay, so this is ventricular tachycardia. Why do I call it ventricular tachycardia? It is because this is the R wave, first R wave, this is the second R wave. Okay, so again, between two R waves, I hardly have one large square here. So the rate here is around 300 because between every successive R wave, I have just got one large square. So the rate here will be around 300. Now let's check whether it's sinus tachycardia. It's never sinus tachycardia because we don't see behavior. Because to be sinus tachycardia, every P wave should be followed by a QRS. So this is never sinus tachycardia because here we are not seeing P waves. Now, can it be SVT? Because the three differentials of tachycardia for us is one is sinus tachycardia, one is SVT, the third one is VT. Is this SVT? Never, it is not SVT. Why? Because it's not a narrow complex tachycardia. It's definitely wide complex tachycardia. Each QRS here is more than one large square. And whenever it is more than 3 small squares, we call it wide QRS. So this is a broad complex tachycardia. This was a narrow complex tachycardia, and narrow complex tachycardia is called SVT. And this is broad complex tachycardia, and broad complex tachycardia is ventricular tachycardia, or it is called VT. Is it clear? Okay, I hope it's clear to everyone. Now let's move on to other. So this is the next ECG. So again, now we have spoken about ventricular rhythms, and now just by your glance you can understand that each of these are QRS because it's just similar to ventricular tachycardia. What we saw here is the QRS is originating from the ventricle. So whenever the QRS is originating from the ventricle, or whenever the arrhythmia is originating from the ventricle, we are going to get a white QRS. Okay, so this is ventricular tachycardia. So similarly, by using the same concept, you can again say these are also impulses coming from ventricles, because we have got white QRSs here. We have got white. I'll just zoom it better. Okay. So we have got white QRSs here. And since we have got white QRSs, these are the arrhythmias originating from ventricles. These are the arrhythmias originating from ventricles. Now, let's see the distance between successive QRS complexes. Here it is around 4 small squares, but here it is around more than 1 large square. Okay, here it's around 3 small squares. Here it's around 2 small square. That means successive interval between every R wave is changing. And if the number of squares between every successive R wave is changing, is it regular or is it irregular? It is irregular. Okay, we have already mentioned that if the number of squares between every successive R wave is varying, we call that rhythm to be irregular ECG. We call that to be an irregular ECG. So whenever we see irregular ECG, what all comes to your mind? We have discussed one is atrial fibrillation, one is ventricular fibrillation, and 2 more things that can mimic the irregular. Let's keep that aside. Other than that, the 2 most important thing is atrial fibrillation and ventricular fibrillation. So this is irregular, and I have already shown you ECG of atrial fibrillation, which means this is definitely VF. This is ventricular fibrillation. This is how an ECG of ventricular fibrillation looks like. Is it clear? Okay, now why is this ventricular fibrillation? First reason, first and foremost important thing is this ECG is irregular. That's why it is ventricular fibrillation. And second thing is the QRS here is wide. In atrial fibrillation, QRS was narrow because the impulse is originating above the ventricle. In ventricular fibrillation, QRS will be wide because impulse is originating within the ventricle. I hope it's clear. So this is the ECG of ventricular fibrillation, and this is the ECG which you usually see in movies. Right, whenever somebody dies, the monitor becomes just a flat line, and this flat line is called asystole. This is called asystole. Whenever patient goes to cardiac arrest, it's called asystole. So this is a rhythm of cardiac arrest. I hope it's clear. Now, just for curiosity, many people still will be having doubt that what's the difference between a cardiac arrest, a heart attack, and a heart block. I hope many of you might be knowing the answer, but still some may be confused. What's the difference between cardiac arrest, heart attack, and heart block? I'll explain. Cardiac arrest is when your heart stops to beat. Okay, your heart suddenly stops to beat. Why? There are many reasons. We usually call them 5H and 5Ts. 5H is something like hydrogen ion, that means acidosis, hyperkalemia. Okay, and 5Ts, that is toxin, tamponade, something like that. So there may be many reasons, but what basically happens in a cardiac arrest is heart stops to beat. That's cardiac arrest. Second one, what is heart attack? Heart attack is another name, layman's term for MI or angina or CAD. Okay, whenever the blood flow to heart is reduced or tissue undergoes necrosis, we call it an MI, myocardial infarction, and layman's call it heart attack. So heart attack is basically the decrease in blood flow to heart. It's never the stopping of heart. Whenever heart stops to beat, that is cardiac arrest. Heart attack or MI is decreased blood flow to heart. And the third important thing is heart block. Heart block has got no relation with heart attack or cardiac arrest. Heart block is basically the disorder of conducting system of heart. Okay, heart block is basically a disorder of conducting system of heart. Is it clear? Okay, so I hope everybody is aware of the difference between a heart block, a cardiac arrest, and a heart attack. Okay, cardiac arrest is basically heart stops beating. MI or heart attack is decreased blood flow to the heart, and heart block is decreased conduction in heart. That means the nodal conduction, AV nodal, SA nodal, the button branch. Okay, so that's the basic thing. So this is asystole. This is a rhythm of cardiac arrest. I'm not going to actually have planned to discuss about cardiac arrest and all, but due to the limitation in time, I'm not going to cardiac arrest and all, because there are 4 rhythms in cardiac arrest. We have pulsosity, we have VF, we have pulsus electrical activity, and we have asystole. But we are not going to that because it will take much time. So we have dealt with one of the most important things that you guys are going to deal with in an emergency. Okay, this is the most important thing. One is ischemic changes or heart attack that I'll be coming. We have already dealt with the basics of the heart attack or MI. But the second most important thing that a doctor is not supposed to miss, that an MBBS doctor is not supposed to miss, is an arrhythmia. And we have dealt with every single arrhythmia. I hope it's clear to everyone. We have dealt with atrial fibrillation, we have dealt with atrial flutter, we have dealt with SVT, we have dealt with VT, we have dealt with ventricular fibrillation, and we also dealt with asystole. These are the important arrhythmias you are going to deal with whenever you are going to practice. I hope every arrhythmia is clear to everyone. And can you please give me please just give me a confirmation if it's clear to everyone. We have already passed 1 hour. I will be just discussing about ischemic changes and we'll be winding up. Actually, I have planned for much more, but due to the limitation of time, we'll be just, if you we can continue in coming session, but for the time being, we can just come end up with the ischemic changes. But before that, is it clear to everyone? Is arrhythmia clear to everyone? Please give me a comment and we'll continue. Is it clear? Yes, everybody is saying it's clear. Okay, so let's continue. So we have discussed about the arrhythmia and all. So next is about axis, but what for the time being, I'm actually skipping axis because we have limitation in time. Just let me know in the comment section that if you guys have got time, I'm more than happy to discuss. Okay, because I started at only 8:45 because of some technical issues. So we have already lagging behind, and hence I'm just keeping access for the time being because we have got more important thing to discuss. We shall discuss this in coming sessions. Okay. For the time being, I'm skipping axis and I'm moving on to ischemic changes. And this is the most important thing you need to know whenever you get a new ECG. Okay, whenever you get an ECG, this is the most important or most common scenario you are going to have when you start practicing. So let's speak about ischemic changes. So ischemic changes and arrhythmia. If you are well and good with ischemic changes and arrhythmia, it's perfectly fine for you to practice. Okay, you're not going to kill a patient. That's what basically happens. Because most important things that kill a patient is one is ischemic changes, that is acute MI, and the second thing is arrhythmia, because arrhythmia can cause certain damage. Arrhythmia can cause a syncope. Arrhythmia can cause embolism. Okay, it is arrhythmia is deadly. Second deadly thing is ischemic changes. So if you are well and good with these two topics, you are perfectly fine to practice. Okay, so these are the two important topics we are going to discuss. So for the basics of ECG, basics of ischemic changes, we have already discussed. That means we have discussed about the valves. I am just brushing it up again. That is, which are the valves of ECGs we have dealt with? One is one AVL, V5 and V6. One AVL, V5 and V6 corresponds to the lateral wall. I have shown you how to read an ECG. One was here, AVL was here, V5 and V6 was here. Okay, that was a lateral ECG, lateral wall ischemia. And second one is inferior wall ischemia. How's in inferior wall ischemia diagnosed? The changes will be the leads, lead 2, lead 3, and lead AVF. Lead 2, 3, and AVF corresponds to the inferior wall. And how will be diagnosed in anterior wall ischemia? There will be changes in lead V1, V2, V3, and V4. So in the basic session, I have discussed that just to discuss this topic with you. Okay. So we are starting with the ischemic changes. So we know the leads, which all leads correspond to which all valves. Well and good. We have two type of ischemic changes. I'm not discussing about the unstable angina, stable angina. Just we know that we can classify it as unstable angina, stable angina, or but for a point of view of ECG, we just need to know there are two types of changes you can get in ECG. One is STEMI and one is STEMI. And as you all guys know, STEMI is an emergency. STEMI is also an emergency, but STEMI is an ultra emergency. Okay, you can save the life of a patient if you diagnose and intervene properly at the proper time for a patient with ST elevation and MI. So you know I hope everybody knows the full form of NSTEMI and STEMI. NSTEMI means non-ST elevation MI, and STEMI means ST elevation MI. So what all changes? Here the word itself denotes. It says that there will be STEMI. STEMI means ST elevation. So the ECG find here, it's obviously there will be ST elevation. And what are we going to see in a patient with NSTEMI? There are mainly two changes in a patient with NSTEMI. One is ST depression. One is ST depression. And second one is T wave inversion. We have ST depression and T wave inversion. So we are well and good with the waves. We know what is ST segment. I'll just show you what is ST segment. Okay. So in a ECG, whenever we are looking for ischemic, when do you look for ischemic pain, ischemic changes? When the patient presents with a typical anginal pain. And how is a typical anginal pain? A typical anginal pain will be a central aching type of pain. Patient usually comes with, there will be associated autonomic symptoms like patient may be having sweating, that means excessive diaphoresis. Patient may be having vomiting. The pain may be radiating to the left arm. Okay, so that's how a classical anginal pain is described. So whenever you see a classical anginal pain, especially with patients with vascular risk factors, what can be the vascular risk factors? Or vascular risk factors can be diabetes, it can be hypertension, it can be dyslipidemia, it can be obesity. Okay, so these all can be the vascular risk factors. So whenever a patient comes with vascular risk factors and a typical chest pain, we are suspecting angina and we take an ECG. And I'll show you an ECG. So what all changes are we looking in a patient with ECG? Ischemic changes. One is the changes of NSTEMI and second one is the changes of STEMI. Okay. So let's look at this ECG. But before finding what is abnormal, let's see what is normal. So I'll just magnify it for you. So this is our ECG. Okay, this is our ECG. So whenever I see, just see here, how will we see, diagnose or will interpret an ECG to be having ST elevation or ST depression? I'll just show you that. So what is an ST segment? An ST segment is, we know that this is the QRS complex. Okay, this is the QRS complex. Here we are having the R wave and then we are having the S wave. Okay, is it fine? So we have the R wave and then we have the S wave. So this is the S wave, this is the T wave. So the segment isoelectric line between S and T. Okay, the isoelectric line between end of S wave and beginning of T wave marks you the ST segment. So this is the ST segment. So whenever you are looking for an ECG change in a patient with MI, your point or the point you are going to focus is the ST segment. That means the isoelectric line between the end of S wave and beginning of the T wave. Is it clear? Is it clear? Okay, I'm looking at the point at the end of S wave and beginning of the T wave. Okay, so I'll call this as the ST segment. So I need to know whether the ST segment is elevated or if the ST segment is depressed. I need to know that. Okay, so to know whether an ST segment is elevated or it is depressed, what I do usually is I'll compare it with the TP segment. So this is the TP segment. Okay, this is the TP segment. Okay, TP segment means end of T wave to beginning of P wave. So I'll just compare, I'll show you, I'll just compare it with the TP segment. So here we have the TP segment here, the ST segment here. So we can say that the ST segment and TP segment are at same levels. So if the ST segment is at the same level of TP segment, ST segment is neither elevated nor depressed. Is it clear? If the ST segment is at the same level of the TP segment, then we can say that the ST segment is neither elevated nor depressed. Just like here in the rhythm strip, we know that this is the rhythm strip. So in the rhythm strip, when we see the ST segment at the same level of TP segment, we can say ST segment is neither elevated nor depressed. Is it clear? Okay, now let's look at this ECG. So when I'm looking at this ECG, I have the lead one here. And in lead one, when I follow the waves, I see a P wave here. And after P wave, I see a QRS here. Okay. And after QRS, what I see is, this is the ST segment. Okay, this is my ST segment. I'll zoom it further. See, this is my lead one. Okay, this is my lead one. So in the lead one, this is my ST segment. This is my ST segment. So ST segment means this is my ST segment. Is it clear? Okay. Now, what did I say? To know whether ST segment is elevated or depressed, I'll compare it with the TP segment. I'll compare it with the TP segment. So this is my T wave. Actually, my T wave here is inverted. What I expect is a T wave like this. But what I get here is a T wave like this. So I'll call it as an inverted T wave. I'll call it as an inverted T wave. So one finding I have got here, that is, it is the T wave here is inverted. The T wave here is inverted. Is it clear? Okay. Now the second thing I see in this ECG is, here I have got an ST depression. Why do I say that? Because this is the end of T wave, this is the next P wave. So this is the TP segment. So I have TP segment at a higher level than that of an ST segment. Or in other words, I can say that my ST segment is at a lower level than the TP segment. That means the ST segment is depressed. Is it clear? So here my ST segment is depressed. My ST segment is at a lower level than TP segment. So whenever I look for an ST elevation or an ST depression, Whenever I look for an ST elevation or an ST depression, I am going to compare it with the TP segment. Is it clear? So here my ST segment is depressed and I have got a T wave inversion. And I have already told you that the changes in an STEMI is ST segment depression with T wave inversion. So from the data I have already shown, one thing is pretty clear. That is, lead 1 is showing changes of STEMI. Lead 1 is showing ST depression plus T wave inversion. Okay. Now, after looking lead 1, which is the lead I took? Is it lead 2? No. After looking lead 1, the lead I am going to look is lead AVL. The lead I am going to look is lead AVL. Okay, the lead I am going to look after lead 1 is lead AVL. Is it clear? So again in lead AVL, I am seeing an inverted T wave here. Also again I have gotten ST depression here. So I have ST depression and T wave in lead 1. I have ST depression and T wave inversion in lead AVL. Now which is the lead I look? I am going to look at lead V5 and lead V6. Okay, again in lead V5, I have got an ST depression, I have got a T wave inversion. I have got an ST depression and T wave inversion. In lead V6 also, I have got an ST depression and T wave inversion, which means, is this an STEMI or STEMI? Has I got any ST elevation? You can look at lead 2, you can look at lead 3, you can look at lead V1, you can look at lead V2. I have never got an ST elevation here. The only findings I have got here is one is ST depression and one is T wave inversion. And in which leads do I get this? I get this in the lateral leads. I get this in the lateral leads. So this is basically a lateral wall and STEMI. This is basically a lateral wall and STEMI. Guys, we definitely have time as a limiting factor. You guys know that nobody can teach ECG within 1 hour. But what I am trying to do here is to convey the most essential things in 1 hour. Okay, so this is how a lateral STEMI looks like. Had it been in inferior STEMI, how it would be? There will be ST depression or T wave inversion in lead 2 and lead 3 and lead AVF. Okay, so that's how we look. If whenever I see, so I have seen here, I have seen changes in one ABL V5 and V6. If one ABL V5 V6 were normal, I would look at 2 3 AVF. If 2 3 AVF has got ST depression or T wave inversion, I will call it as inferior STEMI. I will call it as inferior STEMI. If there will be changes in V1 to V4, I will call it as an anterior STEMI. Is it clear? So that's how we comment ST elevation and ST depression in ECG. We just compare it with the TP segment. That's the thing I used to do, and I find it very useful. Just to compare the ST segment with the TP segment. Is it clear? Okay. So that was the lateral STEMI. I'll show you another ECG. This is actually an ECG from my cardiac ICU. I just went to my cardiac ICU, took some photographs from the patients there. Some of them will be definitely having STEMIs. Okay, STEMI is such a common thing. Okay, so what do you find in such this ECG? So I'm again starting at lead 1. Look at this ECG. I'm zooming it for you. Look at this. I'm starting at lead 1. So what I see at lead 1 here is, in lead 1, I'm seeing a P wave here. Okay, here the P wave is not so clear. I'm seeing a P wave here. After P wave, I have a QRS complex. Okay, I have a QRS complex. And after the QRS complex, I have got the ST segment. So I'm just marking the ST segment here. I'm marking the ST segment here. And when I compare this ST segment with this subsequent TP segment, I definitely can say that there is an ST elevation there. I definitely can say there is an ST elevation there. So ST elevation is the ST segment is at a level higher to that of TP segment. So with these findings, I can definitely comment that there is an ST segment elevation in lead 1 because the ST segment is at a higher level than a TP segment. ST segment is at a higher level than the TP segment. Okay. So I can say that the lead 1 has got ST elevation. So whenever I see ST elevation in lead 1, what I'm going to look, I'm next going to look at lead AVL. Is it clear? I'm next going to look at the lead AVL. So here the lead AVL has again got ST elevation. Okay, lead AVL has also got the ST elevation because ST segment is at that of higher level than that of TP segment. Okay, now what I'm going to look? I'm going to look at lead V5. And lead V5, actually the ST segment is subtle here because the end of QRS is marked by the beginning of T wave. And this is because this ST segment is just short here, but still, if I mark a point between the end of QR and beginning of T wave, this that point, and this is my TP segment. And when we compare these two, we can understand that there is again an ST elevation in lead V5 and in lead V6 also. This is actually lead V2. We have got an ST elevation V2 also. I'll come to that. But before that, just know that here this is my ST segment. This is my ST segment. This is the end of the QRF. This is the beginning of next T wave. So this is my ST segment. This is my next TP segment. So ST segment is at a higher level. So which means I have got an ST elevation. So I have got ST elevation in lead 1. I have got an ST elevation in lead AVL. I have got an ST elevation in lead V5. I have got an ST elevation in lead V6, which means this is lateral wall STEMI. This is a lateral wall STEMI, and whenever you see a STEMI, that is very, very emergency. If you are not in a cardiology center or if you are not in a tertiary care hospital, you need to refer. Okay, you need to refer. So I'll come on to the questions later, but just me finish the basics. Okay, so that's how this is the lateral wall STEMI. Now, before going to further, I'll just see the inferior leads and the anterior leads. So when I see anterior leads here, this is lead V1. So here, this is the end of S wave and this is the beginning of T wave. Okay, so I have got a short ST segment there, but still that short ST segment is at much higher level than that of TP segment. So V1 has also got ST segment elevation. V2 also has got ST segment elevation because this is my ST segment. V3 has also got ST segment elevation and V4 has also got ST segment elevation, which means I have ST elevations in lead V1 to V4 also. That means this is not just a lateral MI, this is actually an anterolateral MI because I have got ST elevations in both anterior leads and also in lateral leads. So I have got elevations in anterior leads and lateral leads. So this is actually an anterolateral STEMI. Why? Why did I call it as anterolateral STEMI? Because I have got. Why do I call it as STEMI? Because I have got ST elevation. Why do I call it an anterior lead? Because I have got ST elevation lead V1 to V4. Why do I call it as a lateral wall STEMI? Because I have got ST elevations in lead 1 AVL, V5, V6 also. Is that clear? Is that clear to everyone? So this is the most important thing, guys. This is the most important thing for you. You need to diagnose NSTEMIs and you need to diagnose STEMIs. Okay, you need to diagnose NSTEMIs and you need to diagnose STEMIs. And obviously, STEMI is far more important than NSTEMI. NSTEMI is also important, but STEMI is an acute emergency. Okay, it's just like a stroke presenting to you in window period. Okay, it's just similar to stroke presenting to you in window period. So, is it clear? So, what I did here is I have left many things. Okay, actually, I was planning to discuss, for example, in this ECG itself. So, in this ECG itself, you guys might be seeing ST depressions here. Okay, there is ST depression lead 2. This is the ST segment. This is the DP segment. So when I compare those two, there is a depression in ST segment when compared to DP segment. So in the inferior leads, lead 2 has ST depression, lead 3 has ST depression, and lead AVF also has got ST depression. This is one of the ECG from my ICU. Okay, this is ECG from my ICU. So there are ST depressions in lead 2, 3, and AVF. So those are called reciprocal changes. I am actually not going into that level now because it's already 10:05. I am planning to wind up at least by 10:15 p.m. and I just need to take on your questions and we'll be winding up it by 10:20 and all. Okay, rest we can discuss as a separate session. If you guys are interested, if you guys find it helpful, we can discuss it in a separate session because even in this single ECG, I have not mentioned all the findings. Okay, because it has got reciprocal changes. What are reciprocal changes? Reciprocal changes, I can just tell that whenever actually the record is in ECG occurs because whenever an impulse passes towards an electrode, whenever an impulse passes towards an electrode, there will be a positive deflection. And whenever an impulse passes away from the electrode, there will be a negative deflection. So actually, when in that interval triangle, I'm not showing it again. Actually, in the interval triangle, inferior leads and lateral leads are opposite. Lateral leads lies opposite inferior leads. Okay, lateral leads were somewhere here in the interval triangle, inferior leads were somewhere here. So they are almost opposite. So an impulse passing towards lateral lead, that means something which produces an ST elevation in lateral leads will produce an ST depression in inferior leads because they are opposite. And that is called reciprocal changes. So about reciprocal changes, I'm not discussing much because it's not a ECG Pro class here. What we are discussing is about the basics of ECG, and considering it as the basics of ECG, I think I have covered every single point which an intern requires. because we have completed the most two important emergencies that an intern is going to address when he is sitting in casualty. One is STEMI and NSTEMI, and we have discussed classically discussed changes in the NSTEMI and STEMI and the changes in arrhythmia. We have discussed every single type of arrhythmia. I hope this changes in ECG, like the changes in ST elevation and STEMI and NSTEMI is clear to everyone. If this is clear, I can just somebody is asking what are reciprocal changes. I'll discuss, I'll take it out. So what about AVR lead? AVR lead, if I start discussing about AVR lead, it's a whole different topic. Okay, so for the time being, I'll restrict it. AVR lead, it's the only lead when we see in Indovans triangle, it's the only lead that comes at this point. Okay, and it has got significance. For example, like in LMCA pollution, there will be a deviation in AVR and the global ST depression. Let's not go to that. Okay, we'll discuss about that later. So is the changes, I just need to know what I intended about this session is I just wanted to clear, or I just wanted to show you ECGs of certain arrhythmias and certain ischemic changes. Is that clear to everyone? Is any point, is what all I have taught here, what all we have discussed here, is any point confusing, or do I need to repeat any of those points in arrhythmia and ischemic changes? Let me know now. So everybody saying is that it is clear. So I think with this, I'll just show you some ECGs. Actually, I have prepared for more. We have already skipped axis. Now we have bundle branch blocks. Bundle branch blocks actually is extremely important because left bundle branch block is actually equal to STEMI. So that's why I'll just tell you about left frontal branch block alone. Okay, let right frontal branch block be there because new onset LBBB. There is a dictum called. There are certain things called STEMI equivalence. There are certain things called STEMI equivalence because all STEMIs does not present as ST deviations. And most important STEMI equivalent is an LBBB. A new onset LBBB. A new onset LBBB is equal to STEMI. This is a dictum in medicine, guys. A new onset LBBB is equal to STEMI. That means you need to identify or you need to know how to diagnose a LBBB or how to find the ECG of an LBBB. Okay. So, first thing, whenever you suspect a bundle branch block, what is bundle branch block? What is AV block? What is SA block? These are the three types of conduction defects we can get in heart. Okay, there can be delay in SA node, and we usually don't see that. Okay, that's why I'm not going to discuss about nothing about SA block. Next thing is AV blocks. That means there are conduction delay between the atrium and ventricle, and we call them as AV block or atrioventricular blocks. And atrioventricular blocks, we have got a series of ECGs. There can be type 1, there can be there can be first degree AV block, there can be second degree AV block, and second degree AV block is further classified as type A and type B. Type A is called Wenke-Back phenomenon, and we have the third degree AV block. But AV blocks has got its significance, but bundle branch blocks, especially left bundle branch block, is very important. So in bundle branch block, the important findings, whenever you suspect bundle branch block, I'll tell you when you should suspect bundle branch block, but whenever you suspect bundle branch block, a single lead to look is onto V1. A single lead to look onto is lead V1. Okay, is everybody still there? Yeah, everybody is still there, so we can continue. I'll just discuss bundle branch block and we are going to end up. Okay, because this is important. Okay, so whenever we suspect a bundle branch block, we are going to look at the lead V1. Okay, so in lead V1, there are certain changes in LBBB and certain changes in RBBB. I'll come to that. But before that, when will we suspect bundle branch block? That's more important, right? Because whenever you see ECG, we have to get some points to suspect bundle branch blocks there. So in lead V1, before that, when should we diagnose or when should we consider a bundle branch block? We will consider a bundle branch block when we have a wide QRS again. Why? Why does bundle branch block produces wide QRS? It's an important question. That's simply because in bundle branch blocks, what happens is impulses up to AV node is perfectly fine. And whenever we comes below the AV node, we have got the right bundle and we have got the left bundle. If the block is somewhere in the right bundle or the left bundle, that's how we get a bundle branch block. So we know that the right bundle supplies the right ventricle, the left bundle supplies the left ventricle. That's perfectly fine. So whenever there is a bundle branch block, the conduction in the bundles, the right bundle or the left bundle will be slowed. That means the time taken for the impulse to spread within the walls of the ventricle will be increased. That's quite logical, right? Whenever there is a block in the conduction system in the right bundle or the left bundle, the impulses will take more time to travel within the ventricle. And if the impulses take more time to travel within the ventricle, the QRS is going to be wide. Why? Because QRS is due to the depolarization or due to the contraction of the ventricle. So in bundle branch block, the impulses are taking a lesser time to travel through the ventricles. And whenever the impulses take a lesser time, the impulses are slow down and it will take more time. The impulses are slowed down in the bundle branch block and it will take more time to travel through the ventricle. And if it takes more time to travel through the ventricle will take more time to depolarize or it will take more time to contract. And if the ventricle takes more time to contract, naturally the QRs will be more than 3 small squares. So whenever you see white QRS, this is our next dictum. So I have told you, whenever you see tachycardia, what all you should consider. Whenever you see bradycardia, what all you should consider. Now, whenever you see white QRS, we have to consider, one thing to consider is bundle branch block. I will write it as triple B. And the second thing to consider is ventricular arrhythmias. Because I have already shown you that in VT and in VF, right? In VT and VF, it was white QRS because simply it's an arrhythmia arising from the ventricle. And the third thing to consider is a ventricular ectopic. So basically, the simple concept, even if you don't memorize this, the simple concept is that anything arising from the ventricle will have a wide QRS, and anything arising from above the ventricle will have a narrow QRS. Anything arising from the ventricle will have a wide QRS, and anything arising above the ventricle will have a narrow QRS. So whenever you see wide QRS in an ECG, what is wide QRS? Wide QRS means the length of QRS is more than 3 small squares. So this is why I told you the duration of QRS there itself. And I have already told you the duration of PR interval also. That is because in heart blocks we need that. But at today's session, we are not going to discuss heart blocks because heart blocks will take time. Heart blocks will take at least 20 minutes. We are already lagging behind time. So by discussing bundle branch blocks, after discussing bundle branch blocks, we are going to conclude. Okay. So whenever you see white QRS in ECG, we are going to consider three things. Whenever we see white QRS, we know that the impulse is coming from ventricle. We are going to consider it is either a bundle branch block. Bundle branch block is due to the delay in conduction in ventricle. Second one we are going to consider is a ventricular arrhythmia like VT or VF. And third thing we are going to consider is a ventricular ectopic. Is it clear? Okay, so anything arising from the ventricle will be having white QRS. So I am building your basics, guys. So this is what we need. If you know these all things what we have discussed in this session, the coming sessions will be very useful, or the coming sessions will be pretty easier for you to understand. Okay. So I have told you that. So I am seeing white QRS here. I am seeing white QRS here. You can see that this is the normal QRS. Normal QRS means the length of the QRS, the beginning of Q wave to the end of the R wave, it is less than 3 small squares. But here you can see it's about 1 large square. I will zoom it further. See. I hope you have noted this already down. So here, this is how a normal narrow QRS looks like. This is a wide QRS. Wide QRS means the length of the QRS is more than 3 small square. Okay, again here we are seeing two R waves. How to call it a R wave that I'll discuss, but we actually don't have time. Just simply know that a first positive deflection after the P wave is called the R wave. Just try to understand what I'm speaking. Okay, first positive deflection after the P wave is called an R wave. Okay, a negative deflection before the positive deflection is called a Q wave. That's how we define a Q wave. It's not like every time you will see this. Okay, not this. Every time you are not going to see this. Okay, first positive deflection after P wave is called an R wave. Okay, a negative deflection before the positive deflection. Okay, this is the positive, this is the basic, that's why I'm discussing. First positive deflection after a P wave is called R wave. So this is an R wave. Okay, a negative deflection before the positive deflection. So we have the positive deflection here. A negative deflection before the positive deflection is called the Q wave. And a negative deflection after the positive deflection is called S wave. That's how we name the different waves in ECG. Because every time when you look into an ECG, you're not going to find a classical ECG like this, because many times you're not going to see Q wave at all. What you usually see is after the P wave, we will be having something like this. We are not going to see Q wave everywhere. So that's how we define. So in this, we'll be having doubt whether this is to be called S wave or to Q wave, because it's a negative deflection. So that for that we have the convention. First positive deflection is called R wave. This is the R wave. And if you have a negative deflection before the positive deflection, we call it a Q wave. So here there is no Q wave because we don't have a negative deflection before the R wave. And a negative deflection after the R wave is called an S wave. So this is the S wave. So in LBBB, we have first thing important here is we have wide QRS, because the QRS is wide, because the QRS is more than 3 small squares, because the QRS is more than 3 small squares. And second important thing in LBBB, what we are finding is here we are having absent R wave in lead V1. I told you whenever you see LBBB or RBBB, we are going to look into lead V1. So this is an LBBB. We are absent R wave. We don't have an R wave. That's the classical finding of LBBB. Second, we have a deep S wave. We have a very deep S wave. Okay, and we have a wide QRS. So actually, we have got codes like William and Marrow. Many of you might have heard that. I'll discuss about William and Marrow in coming sessions. But for the time being, what I find more useful than William and Marrow is, some of you might not be familiar with William and Marrow, but there is some code like that for LBB and RBB. Leave it aside now for the time being. But understand that whenever you are suspecting a bundle branch block, when will you suspect a bundle branch block? When you see a white QRS. When you see a white QRS, you are going to consider 3 things. It's either a bundle branch block or a ventricular arrhythmia or a ventricular ectopic. Ventricular arrhythmia ECG I have already shown you. Ventricular tachycardia will be something like umbrella shaped. It will be regular. Ventricular fibrillation, it's a chaotic ECG. Like it's irregular and it has got wide QRS. So that's how a ventricular arrhythmia will be. Ventricular ectopic I'll show you, but for the time being, concentrate on bundle branch blocks. So we have got a wide QRS. We have got absent R wave. Note it down. In LBBB, we have got absent R wave in V1 and a deep S wave. We have got a deep S wave. So we have got an absent R wave and a deep S wave. This is classical of LBBB. Okay, and LBBB is very important because a new onset of LBBB. If you see LBBB in any patient, if you see any LBBB in any patient, what you immediately do is to ask them for their old ECG. And if their old ECG also shows LBBB, it's fine. That means you don't have got any emergency. But if that LBBB is of new onset, should be treated like STEMI. You should urgently refer them. Okay, so that's what I taught, that I discussed before. That means a new onset LBBB should be considered equivalent as that of STEMI. A new onset LBBB should be considered equal to that of STEMI. I hope it's fine. RBBB, this is called an RS-R- pattern because first positive deflection, this is an R wave. Right, this is an R wave. And a negative deflection of the R wave, this is the S wave. And we see a positive deflection after the S wave. This is not what we see usually. But in RBBB, after an R wave and then an S wave, we see another positive deflection. So the second positive deflection, we call this as an R dash. We call it as an R dash. So in RBBB, what we find is an RS-R dash pattern. We find this RS-R dash pattern. This is classical of RBBB. And RBBB usually it is benign. That means it doesn't cause much problems. But LBBB is important. So that's briefly about bundle branch blocks. We have more things to discuss. We have to discuss the changes in week 6 also. We have to discuss about William and Marrow. That's the code for LBBB and RBBB. But for the time being, let's leave that aside. But whenever you're practicing, whenever you're suspecting bundle branch block, you need to look at V1. Even if it is LBBB or RBBB, the most obvious change is going to be happening V1. In LBBB, there will be an absent R wave, there will be deep S wave. In RBBB, what we find is RS-R dash. Okay. So let's see this all aside. Actually, this is actually an LBBB. Okay. And just look at the V1. Just look at the V1. Okay. Here what you find is the QRS is wide because QRS is more than 3 small squares. It's about 4 to 5 small squares here. And the second thing here is there is an absent R wave and deep S wave. There is absent R wave and deep S wave. So this is naturally LBBB. We have a wide QRS, number 1 point. Number 2 point, there is absent R wave in lead V1. And number 3 point, and there is a deep S wave in lead V1, which makes it an LBBB. And if it's they're not there in their old ECG. This is STEMI equivalent. You should refer this question. And with this, I'm concluding, guys. Okay, with this, I have left many things. I have not discussed about heart blocks. I have not discussed about LBH. I have not discussed about the axis of the heart. I have not discussed about the reciprocal changes. I have left many topics. I know that. But at from an intern's point of view, what is most important is arrhythmias, changes in MI, ischemic changes in myocardial infarction, and LBBB. Okay, these are the three most important. Actually, I have got more ECGs from my hospital. I have got many ECGs with atrial fibrillation, with anterolateral MI, with posterior wall MI, with infralateral MI. I have got many ECGs, but since the time is limited, I am not showing that. But if you are thorough with what I discussed till now, that means the changes in arrhythmia, the basics of ECG, the ultra basics of ECG we have discussed. Like we have started with the rate of an ECG, rhythm of ECG. We have discussed about tachycardia, bradycardia. We have discussed about the squares, how each square, what is the duration of each square, what is the normal duration of PR interval, what is the normal duration of a QRS wave. We have discussed different arrhythmias like atrial fibrillation, atrial flutter, ventricular tachycardia, ventricular fibrillation, asystole, supraventricular tachycardia. We have discussed all of them. We have discussed about different leads of ECG, which all lead corresponds to which all walls of the heart wall. And we have discussed, I have shown you many ECGs showing ischemic changes. I have shown you ECGs of STEMI. I have shown you ECGs of STEMI. Now I have left many things. I have many things to discuss. And importantly, I have also discussed you with LBBB, because LBBB also presents acute emergencies. So these arrhythmias, changes in MI, and LBBB was the most important topics, and these are the most acute emergencies that you should pick up in an ECG. And with this session, I just planned to discuss these topics only. Okay, if time was allowing me, I would have discussed more, but the most important things, what I really wish to discuss today, I have already discussed. So I just want to know a quick feedback whether this session was useful, and in coming sessions, is there any changes that I should make, because there was certain mistakes from our side. Since it was our first session, there was some technical delay. I have been stuck in a traffic block. That was another problem. So that's why our session was initially itself, it was 45 minutes delayed, and we have actually planned for 1 hour session, but it's already 1.5 hours. I have to already 1.5 hours, but it's just because I need to make each and every point crystal clear to you guys. So if the session was useful, just let me know in the comment section, because in coming sessions I need to make many changes. Okay, if I have to make many changes, I need your suggestions. Your suggestions are extremely important. So if my slide, if I need to know about the slide quality, I need to know about my presentation, my speed. Okay, is there any change you need to make? Okay, you can just comment below. You can comment in our group also. So just speaking quickly about RX Global. RX Global is a new initiative started by a group of doctors actually in Calicut Medical College. So what we are planning actually is a global medical education system. Okay, through RX Global, what we are actually planning is a global medical education system. So in RX Global, you can get guidance, and you can get articles, or you can get materials you need to prepare for exams like FMGs, exams like PLAB, MRCP, or the exams, qualification exams for Australia. So basically what we are planning with RX Global is a global communication, global medical system, which encompasses all types of exams a medical student is going to attend after, they can attend after exam. Okay, their MBBS period. So that's what basically we are planning with RX Global. So our initiative, this initiative is actually a webinar series for interns. This was our first session discussing regarding ECG. Our next session will be the psychiatric problems faced by a house surgeon or a doctor, because it's something extremely important. Whenever you start to practice, one thing is pretty clear. This is really a stressful job. Okay, because you have got responsibilities. It's not like you are a nurse or you are like an attendant. You have got responsibilities. Every other one in hospital is going to work according to your orders. So you definitely have got responsibilities. And since you have got responsibilities, this job is going to be stressful. So tomorrow's topic is extremely important. It is mental health changes or psychiatric changes that intern should be ready to prepare. Okay, and the subsequent sessions will be the most important. What we have planned through this webinar series is we are planning to discuss, like when we were interns, there were certain deficiencies. Actually, especially in ECG. ECG was one of the most important deficiency when I was an intern. That means I was reluctant to look into an ECG because I know that I can't find a finding. This is just because I didn't knew the basics, and these were the basics. These are the basics I. And similarly, other than ECG, other thing you need to know is to how to attend night calls. Like when you start to practice, you will get a call like the patient what will be having pulmonary edema. So you need to know how to manage pulmonary edema. You need to know a patient to manage a patient who presents as an anaphylaxis. So those emergencies will be dealt in the a session which comes day after tomorrow, and after that we'll be having a session by Dr. George Papi, who is the radio diagnosis resident. He is actually a senior resident. He has completed the MD radio diagnosis from our medical college. So he will be discussing about important X-ray findings. X-ray is something similar, very similar to ECG, because X-ray also, whenever we see, when we get an X-ray, we just look on into X-ray just to convince the bystander that we know something, but actually we know nothing. So whenever you get an X-ray, we need to know how to interpret an X-ray. So that is also important. So in coming sessions, we'll be having that. So basically, RX Global, through RX Global, you can find it as a common platform for your guidance, whether it be for FMG, PLAB, MRCP, for your CV preparation. So basically, we'll be a one-way or a single solution for all your queries. For all medicos, we are a group of doctors who can help you guide to guide you to different possibilities other than NEET PG. And we will be containing documents, and we'll be having information regarding NEET PG also, but we'll show you all the possible opportunities that you can choose after MBBS. So stay tuned, guys. We'll be having a next session tomorrow, and more importantly, I just need the feedback either in the Zoom comment session, or in the WhatsApp group we have already made. Just give the feedback of the session. And as you all know, I have left many topics. I have even touched hard blocks. I have even touched many things that I already came prepared for, but we can discuss it as subsequent coming sessions. If you guys are interested, just let us know either in this comment session or in the WhatsApp group, where we will be available all the time. So feel free to connect with us. So we'll be having coming sessions. We already have 5 sessions planned in this webinar series itself. And after this webinar series also, we are planning for many more sessions. So let's see in the coming sessions. So I'm just reminding you one last time, your suggestions and your feedbacks are important. So please post your suggestions and your feedback. And if you require more sessions, please let us know in the WhatsApp group. So see you in the next session. Till then, bye. Somebody is asking what about artifacts. Actually, I have not spoken anything about artifacts. Artifacts are some ECG changes that have not got any clinical significance. So how to find an artifact? I can't discuss it at this point level of things we have discussed. I can't discuss about artifact at this point, but just know that artifact is something which we can find. So for example, this isoelectric line may have something like this. It's actually not this big, but it may have something like this. Something we don't expect in normal ECG, and those changes which does not have a clinical significance is called artifact. I'll discuss that in coming session. Okay. So if there is any how to differentiate between acute and chronic changes in ECG. I think you are discussing about that whether a change is acute MI or is it a old change. Actually, you have got many methods to differentiate between acute and chronic changes in MI. For example, one is Q wave. Q wave usually occurs in old ECGs, like old MIs. So if you find a pathological Q wave is a very deep Q wave. It's actually more than 1/3 of the QRS complex. If we find such a Q wave, it can be an old change. One is that. Second is we can ask the patient for their old ECG. Okay, so if some change, if we see some elevations or some depressions, we see some NSTEMIs or STEMI changes, we can ask for their old ECG. If their old ECG is also showing that changes, that is not significant because there is no serial change. We call that as a serial change. So serial changes are always important. Serial changes are always important. For example, I took an ECG now. I took an ECG now. There is a mild ST depression, say, let's say, lead V2. So what I'll do, I'm confused whether it's significant or not, or whether it's an old change or a new change. What I'll do, I'll ask the patient to wait for 1 hour. And at 1 hour, I'll repeat the ECG. and I look for any new changes that the whole ECG didn't have. And if there is any new change, I call it a serial change, and serial changes are significant because something new has occurred in that 1 hour. That means the myocardium of your heart is going to die, or it is dying. So if there is a serial change, again, it's an acute event. Okay, and we can measure the cardiac biomarkers level. We can measure the tropi level. If it is an acute change, there will be elevation tropi. So there is certain methods. I have already discussed 3 methods. We have got many more methods. We have got an echocardiogram. So we have got many methods to differentiate between acute and chronic changes that we can discuss in coming sessions. So, okay, I hope it was fine. Atrial flutter, atrial tachycardia, and atrial fibrillation difference. Someone is asking for atrial flutter, atrial tachycardia, and atrial fibrillation difference. First and important thing, atrial fibrillation will be irregular. That's the most important thing. Atrial fibrillation will be irregular. Atrial flutter will not be irregular. Okay, in atrial flutter, you see sawtooth waves. And you're asking about atrial tachycardia. There is something called MFAT. MFAT is multifocal atrial tachycardia. MFAT is multifocal atrial tachycardia. Actually, I don't think it's needed in your level. It's just the atrial tachycardia. There will be different types in multifocal atrial tachycardia. We'll get different morphologies of PV. Some PV will be like this, some PV will be like this, some PV will be like this. Okay, those are these different morphologies of PV. That is called multifocal atrial tachycardia. I don't think that's needed at your level. It's actually needed, but what we are discussing here is the most important things. So I hope it was useful. I have almost answered for every questions. So I hope you guys found it useful, and please let me know your valuable feedbacks in the comment section. See you all guys later. Bye.